Go. Okay, so thank you everybody for coming again tonight. We have two special guests, Dr. Nayan Patel and Dr. Ray Yutani. I believe that's right. So Drs. Patel and Yutani, they're gonna tell you all about their story. It has something to do with glutathione, which is one of my favorite topics. And if you heard me a little earlier, I told you about Buddy, a dog. It was a friend of mine's dog who was on pretty much his last legs. He was only 5 years old, and he had was in fulminant liver failure. The vet wanted to put him to sleep, and we started treating him with 600 milligrams of glutathione in the scruff of his neck daily for almost a month, and then it sort of we tapered it from there. And Buddy, that was 6 years ago. Buddy is still going strong, and he's been a great dog. And without the glutathione, Buddy would have been gone 6 years ago. So why it worked, I'm not really sure, but maybe our guests here can tell us. So we have a couple of old friends that we haven't seen for a while. We got a couple of new names. So please welcome, and please make yourself known. If we don't have your email address, we'd like to put you on our list so that we can, we can stay in touch. I still don't know how to put this thing on Facebook, so that's somebody could teach me how to do that. That would be a help. We are on LinkedIn. We are, just so you know, that we are both the American Osteopathic Society of Rheumatic Diseases, and I won't go through the whole thing, but we've been trying to change it to integrative medicine, but they're not too crazy about that at the AOA. And we also are the Integrative Health Alliance. So Dr. John Burgess down here is my right-hand man. And we've been doing these webinars for almost a year now. We're getting more and more popular. We get some really top-notch talent. We got John Swartz here from Pharmanex, Dr. Kathleen O'Neill Smith, who's one of the superstars in the anti-aging world. Among others, Dr. Halassa, who's the impetus of all of this. He was a thorn in my side until I finally got off my duff and got it going. So, we are, and we'll talk at the end. We are only a week and a half away from OMID, which is the AOA Scientific Convention. We'll go into that for anybody who's interested in that. Unfortunately, it's online and not live. We should have been going to Phoenix next week, but that's a whole nother story. So I'm going to just introduce Drs. Patel and Yutani. They're over to my right here. This is Dr. Patel. This is Dr. Yutani, even though it says Dr. Patel. And they're going to tell you their story. And we're going to, you're going to learn a little bit something about glutathione. And of course, if there's any COVID tie-in, gentlemen, please let us know. Although I'm kind of sick of the whole thing myself, but that's one of the things they're interested in. So I'm going to let you take it away, and I will be here if you need me. Okay, so introduce yourselves and tell us what we need to know.
All right, thank you, Dr. Clearfield. I'm Dr. Nayan Patel. I'm a pharmacist by trade, and I have been working at a compounding pharmacy for over 25 years at Central Drugs Compounding Pharmacy up in California. And our focus has since day one has always been trying to create better medicine for our patients. That was our goal from the get-go. And so in 2009, we were working on a molecule, vitamin C, of course, trying to make it liposomal and try to get the liposomal vitamin C into lyophilized powder so we can take it orally. We don't have to take this sludge of vitamin C. And it was not my calling at all because it was not working very well for my patients. And so we were working on glutathione, vitamin C, and all those other molecules at that time. And so long story short, we started working on glutathione and discovered a way to stabilize the glutathione for the very first time under water condition at room temperature, and hence the start of the Glutathione revolution for me. So I'm going to share a screen right now and see if I can show you. I prepared something. It's nothing. It's not something too crazy. I hope so. but let me just share with you a little bit. So the glutathione level, I call the final chapter in age management, is because I think once you hear what we have done, what kind of work we have done, I think it's going to open your mind up to see a molecule as simple as glutathione that our body produces on a regular basis. How profound effect does it have on our body? My goal today is to tell you, first of all, how to test for deficiencies. What's the difference between RBC and plasma levels of glutathione? Because there's a big difference between those. Condition diseases that glutathione can have a role in resolving, and effective ways to raise your intracellular levels of glutathione. And I stress the word intracellular over here because you can raise all the plasma levels as you want, but if it doesn't get intracellular levels of glutathione, you literally have 10 minutes to do your work, and that's about it. And I'm not sure what kind of work glutathione can do if it's only been given 10 minutes in your body. So, being said that, let's go over some of my. This is my book, The Glutathione Revolution. The fore was given to me by Dr. Mark Hyman. I'm sure this group already know Dr. Mark Hyman, and of course one of my evangelists, Tony Robbins, who was 3 years ago was suffering, which is in the news already, about his mercury toxicities, and we were able to help him resolve those issues with the topical form of glutathione, which raised him to give us an endorsement about, hey, this is something that we will want to look into it. So let me go with glutathione first. It's the form of testing. The highest level of glutathione is found in the RBCs. Again, this is according to doctors' data. They do all the testings for the glutathione for us. And so we have found that the RBC levels of glutathione is the best way to measure the glutathione levels, compared that to plasma or whole blood. Erythrocytes, glutathione in erythrocytes is an indicator of an intracellular level status, and the goal is to reach over 1,100 micromoles per liter. And I have done some testings in my office over here on few patients that we have done over the years, and the best I saw was about 550 to 600 is what I see in most of my patients, and I've tested anywhere from patients from the age of about 25 to all the way to up to the age of about 65-ish. And so regardless of if they're 25 or 65, we are living in an environment where the exposure to toxins is so high that it's inevitable for us to get away from it. And so because of that, our need of glutathione has increased dramatically, and our production of glutathione cannot keep up with the needs that we have at this point. And hence we are seeing considerably low levels of RBC levels of glutathione in all our patients combined. And of course, if you look at that things, there was a study that was done in Korea about the pharmacokinetics of glutathione, and it just shows about the effectiveness on how long the glutathione stays in your body. And no matter what they gave us, the plasma level was measured, the half-life was only 10 minutes. So it doesn't stay in your body for that long. So we need to have a better way to increase the RBC levels of glutathione, because the RBC levels of glutathione, what we have found out that the half-life is about 4 hours. Now, the reason that the data is based on our internal study that has been done with 5 patients is because there's no studies been done on the RBC levels of glutathione to measure the half-life at this point. I could not find one yet. And because of that, myself, Dr. Yutani, Dr. Venkatraman at the Western University School of Medicine, we have applied for an IRB approval to see if we can do a pilot study for the absorptions and excretions of glutathione and how long does it stay in your body for. And I believe we're doing a 30-patient trial, placebo-controlled trial. So once we get the approval, this trial will be on its way, and we'll have a definite answer for you, hopefully by sometime next year, as to reciprocate the data that we already have on the 5 patients that we did internally over here. The condition that linked to oxidative stress, of course, we can go over the list on and on, because the thing is, it's not about not knowing what the glutathione can affect us, but understanding the oxidative stress is affecting every single cell in your body. As much as we want to understand that we have no no hand in preventing or curing Alzheimer's or having a hand in Parkinson's, we all can help us reduce the oxidative stress that can finally end up in these end-stage diseases that it's really hard to treat. And we all believe in one thing: it's easier to prevent the problem than to treat the problems, especially when it comes to neurodegenerative disorders like Alzheimer's, Parkinson's, ALS, and Huntington's. So our goal has always been, what can we do to help these things out? When I was doing my research, when I introduced this product in 2009, of course it was available through a compound pharmacy. We were looking at working with all the doctors, and then of course the doctors would say, "Hey, I understand your product is good. What other ways can I reach the glutathione levels?" Of course, you can try using the cysteine rich foods like whey proteins. You can take the NAC supplementations, oral inhalations, that's prescription items now. There's oral capsules, there's superiorgogues that can stimulate the glutathione production. You can take oral liposomal glutathiones emulsions. You can take the compounded IV preparations, inhaled glutathione solutions, suppositories. No matter what you do about this ones, the very slight increase in RBC levels and majority of the increase is in the plasma, and that in turn tells us that the effectiveness of this product is not going to be long lasting. It's definitely not going to have a major impact on any end-stage diseases for a solution that we are looking for. When we were designing this glutathione, and later we discovered that it was actually a topical form that is getting intracellularly. Our patent was assigned to us back in 2019. They waited for 10 years for research to proliferate before the patents were issued to us in 2019, even though it was discovered in 2009. So the things that we have worked upon, I believe we are all practical in nature. As much as we would like to hear theories on what it can do, nothing's better than what we have already done in terms of the symptoms instead of the outcomes that we have seen. So in the last 10 to 11 years, this is what we have seen. So at least I can brief you over what we have done as of right now. And what we do from here point onwards is all up to us as to what do we take this information and how do we move forward. So as of right now, the first thing we tried on this product was on high triglycerides. And if you look at the research was not based on cholesterols or triglycerides, was not affected by glutathione. But one of the products that we use to stabilize the glutathione to be delivered topically, we use the protein enveloping method to do so. The product that we used was dextrins. Dextrins are polysaccharide sugar molecules that have known to reduce cholesterols and triglycerides. And so what we were doing is that when we were using the glutathione as a product to be delivered to our patients, what we first noticed was the reduction in triglyceride levels on few of my patients. Of course, right away we called the doctor up, let the doctor know this is what we have seen in few of the patients, and then we worked with the pharmacy out of Texas who had about 34, 35 patients with high triglycerides. And in less than 3 to 4 months, we saw almost 100% reduction in triglyceride levels back to under 150. And so that triggered my mind. I said, what else is happening? And of course, the next thing we started looking was for hyperinsulinemia patients, especially with type 2 diabetics. We saw the insulin level starts dropping, the diabetes started getting better. There was slight reduction in the medications itself. So this was an adjunct therapy. It wasn't a solo therapy. So they were already using some other medications as well. But with the help of glutathione and reducing the oxidative stress, the patients were experiencing better energy levels, better outcomes. They're losing weight because insulin levels was decreasing. And we all know insulin is probably the most atherogenic drug or molecule that we produce in our body, and the damage that's caused by insulin is enormous. And anything that we can do to reduce those levels down or help mitigate some of the side effects or effects that insulin can cause in our body would be a plus point for us. Some of the common things we saw was, the first thing we saw was the cold sores. One of our patients, one of a very good friend of mine, was getting cold sores all the time. And since he started using the glutathione topically, he hasn't got a cold sores for close to 6 months to a year. And that triggered me to say, hey, if we can get rid of cold sores, how about using for shingles and herpes and things like that? And sure enough, we were getting results with shingles and herpes, with the pain management and the lesions getting reduced, and the duration of the infections down from 14 days to under 5 days, and so on and so forth. It really solidified that there's a multiple role for not just glutathione by itself, but also with the help of the polysaccharide molecules that is used to stabilize or use the protein envelope method to deliver the glutathione. Recently, the last 4 or 5 years, we have worked on common flu, and the symptoms release have been within 24 to 48 hours. And that triggered us, of course, recently to work on COVID-19, which I'll leave to Dr. Yutani, because that was his work that he worked on COVID-19 patients at the university, and I'll leave it up to him. We had a couple of cases of post-herpetic neuralgias. Patients were wheelchair bound. There were secondary to some viral infections over the years, and they were able to walk for the first time. They have been in wheelchair bound for quite some time, and they were able to walk for the first time after literally 2 months of using glutathione. So there's some to it. There's more than just the glutathione that is doing the work. And I wish I knew all the answers for you right now, but I don't. And I'm like you, I'm learning on the job at this point. And yes, we have this product, but it's more than the product. We have a way to deliver this molecule. Some of the things that we saw anecdotally is age spots, sunspots. I mean, think about it. People use all kinds of products over the counter to get rid of the sunspots. Imagine just getting rid of it, because of the polysaccharides can dissolve all those cholesterol type molecules under your skin, and with the help of glutathione can lighten all the spots out. Melasma, we have seen great results with melasma being reduced without using lasers or retin-A or any of the other products. So I'm just trying to give you a lot of information at this point, but all I'm giving you is what I've seen as of today. And what's going on. And when we talk about dosing, this is like Dr. Clearfield said earlier for his dog Buddy. He was using 600 milligram for a 30-pound dog. I'll tell you, the dosing that we have seen with the topical glutathione, if I give you 600 milligrams to a 200-pound man, I can get you into major detox, and you can have nausea, you can throw up, you can have intense reactions from this molecule. And so what we have found out, we have done dosing regimens from anywhere from 50 milligrams to 100 milligrams, 200, 300, 400, 600 milligrams. And what we found out was about 100 milligram dose gave you the best cost benefit ratio over time. And this was a study done by a doctor out of Utah, and he did on his patients. I think he did on his on 34 patients that he was hired to do a detox program for a Japanese company. And so while he was doing that, he might as well did this absorption study as to what dose was effective to have a proper detoxing effect. And so what we found was 100 milligrams topically is all you need and lasts your body for 4 to 6 hours. And so that's what we found out, compared to a 30-pound. If I give a 30-pound dog, 600 milligrams of topical glutathione, I'm not sure what's going to happen to him. I really don't sure. But for the dogs, I have a friend of my dogs, and they have all of arthritis. They're all 12, 15 years old dogs, and they have arthritis. They can walk up and down in California. Living in California, we can afford a single-story home. So everybody has a double-story home because that's real estate is so expensive here. Anyways, the dogs cannot go upstairs at night anymore. And so the owners were giving them a couple of sprays of this topical glutathione. And sure enough, in 15 days, the dog was going up and down again for arthritis. So it has worked on arthritis as well. So as I said earlier, the studies that was done by another physician was a 34-patient trial on heavy metal toxicities for a Japanese company. And they're just awaiting publication at this point. Result is significant clearance of all mercury, arsenic, and cadmium at this time. So those are the things that we have observed so far. And I can bore you to death for all the things that we have seen. But my goal today was to just share with you something that we have observed in my clinical practice over the last 10 or 11 years. It's been a very interesting journey for us at this time. And the last year and a half has been completely consumed with trying to figure out how we can help patients that are going through COVID. And so I don't want to take the thunder away from Dr. Yutani because he put tremendous work in this one over the last year and a half. And finally, I'll let him speak on what he has done with his work as well. So Dr. Yutani, you want to take over?
Thank you, Dr. Patel. Now, I'm a low-tech guy, so I got to figure out how to get my slides on the board. I may need some help, man.
If you go down the share screen, right down in the center,
Right
green
down.
there.
Oh, here we go. I got that. There we go.
There you go. Okay. You're and you're a DO too. Wow. All right.
A lot of things. Anyways, I'd like to present what I feel is the path to the end of the pandemic. If we have the vaccine and a treatment, we should be able to get rid of this pandemic. And to be honest with you, I'm tired of this thing. It's been almost 2 years. So I'll show you how this works. Okay. Okay, I have no conflict of interest. Hold on a second. Having a little technical difficulties. Here we go. Again, like I said, it's now coming up to 2 years with this pandemic. And so what have we suffered through right now? Hold on a second. I'm having some difficulty with my, all these numbers here. The bottom line is almost 750,000 individuals in the United States have died so far. It's a number, but if it's your loved one or a friend, it's devastating. So what can we do about it? If you look at right here, interestingly enough, 3 countries, the United States, India, and Brazil comprise almost 40%, over 40% of the total cases. And you can see that, unfortunately, the United States leads the pack. So what I'm going to present is it's a novel outpatient treatment for the COVID virus. What if I told you a year ago that I have a product that will reduce the SARS-CoV virus titer, antiviral, tempers the cytokine storm, which of course is the, the cause of the pathology from the COVID virus illness. It'll prevent the need for hospitalization. And if you're working in ICU or in a hospital, you dearly love this. Prevents, once a person is actually admitted to the hospital, it will prevent the progression of hypoxia needing mechanical ventilation, thereby shorten the hospital course. Reduces mortality, saves some lives, and that's really near and dear to me. Saves the lives of those who are hospitalized in the ICU. Probably treats some of the post-COVID syndrome. It is a repurposed over-the-counter product. When you think about repurposed over-the-counter product of note, think of aspirin. And this is, I think it'll be just like up there with aspirin as far as an OTC product. But think of it this way, it doesn't require a prescription. Cost-wise, it's less than 5% of remdesivir per treatment. The stable at room temperature. This is really important if you're thinking about rural areas and especially the third world countries. You don't have to refrigerate, you don't have to freeze it. It's there in a bottle ready to be used. Okay, technical difficulties again. And most importantly, it is non-toxic. This is so important in view of ivermectin use, hydroxychloroquine, and a lot of other things. And especially if we're thinking about treating neonates and pediatric patients, the fact that it is non-toxic is so important. Of course, that product is Dr. Patel's product, Glutaral. What you see in front of you is the two strengths of Glutaral, the Glutaral plain and the Glutaral plus, which is the high dose that we recommend for use for people that are hospitalized. So about a little over a year ago, that first pandemic crisis, I met Dr. Patel, and he told me about this product, which, to be honest with you, it sounds like snake oil, Dr. Patel. But the more I looked into the background, I realized that this thing probably does work. And about the same time, I was doing telemed visits now because we're no longer in the clinic, and so I started getting members of the clinic staff and their family members, and also my own patients coming down with COVID. And they heard about this Glutaral product, so I figured, well, I need to do at least some kind of a study on this to see whether it works or not. So keep in mind that this was a telemed study, so there's no lab tests, no pulse oxins, things like that. But anyways, this is what I got from the study. As you can see, I had 10 patients, a small cohort study, obviously, of only 10 patients. The age range was from 11 to 83. 3 of the patients had comorbidities of hypertension and diabetes, which we know very well increases the risk of severe illness. 2 were men, and this is the results. There were up to 9 days of delay to start of treatment. So some of these had the illness for 9 days. The days on resolution to treatment from the start of treatment to the end of all symptoms was anywhere from, hold on a second, my slides. With 2 to 8 days. And regardless of the severity of illness or comorbidities or any demographics, the duration from the start of the illness, start of symptoms, to the end of symptoms and full resolution to assess the well-being was anywhere from 2 to 12 days. And as you can see, and you would expect, those with advanced age, comorbidities, severe symptoms such as shortness of breath, delayed to onset of treatment. It took up to 12 days of treatment. But if you look in contrast, if you treated young people with no comorbidities early on, resolution of symptoms in 2 days. So this is the demographic distribution. So shortly after I did my study, there was a publication from New York, I believe, this large study on the outcomes after standard of care treatment. And so it was a multi-state in the New England area, New York and New England area. They looked at the outcomes of people that had COVID illness. And as you can see, on the left is the multi-centered study, and this is my results. And the most common symptoms were pretty much the same: fatigue, cough, headache, body aches, and also smell. And when you look at the multi-state study, of those frequent symptoms, the persistent ones were most frequently cough and fatigue. And they looked at the percentage of resolution, and to summarize it, 2/3 of the patients that they called by this telephone survey had no symptoms after 7 days. But in contrast with that, a little over 1/3 of them did have persistent symptoms, even up to three weeks after the time of positive COVID test. And as you would expect, there was a higher incidence of those with advanced age. But look at this line right here. Relatively young people, 18 to 34 years of age, no chronic medical condition, still 20% of them, 1 out of 5 still had persistent symptoms at 2 to 3 weeks after the testing positive. So in contrast, if you look at summary of my Glutaral case study, no one required hospitalization. This is really significant because this is one of the big goals of healthcare and healthcare costs is, of course, is prevent hospitalization. Mild cases, as I mentioned, we resolved in 2 days. Severe cases took up to 8 days to resolution. Regardless of all comers, 12 days total resolution of illness. They had a feeling of well-being, no fatigue, no nothing. They were well and they felt well. And importantly, none had residual fatigue, which is one of the most common, basically the most common symptoms of the post-COVID syndrome. So of course, we know very well that it's caused by the coronavirus, SARS-CoV-2, with the iconic spike proteins from which it attaches to the mammalian cell. And of course, as we well know, it attaches to the ACE2 receptors on the mammalian cell. That's a lock and key example, and then it's incorporated into the cell where it replicates, and then eventually is discharged into the serum to be attacked by the T cells and B cells with the immune response. Give you an idea of the degree of viremia. This is a scanning electron microscope, I believe, of a white blood cell or lymphocyte perhaps. But each one of these red, yellow dots is a virus particle, so it gives you an idea of how the attack of the virus is on an individual cell. I'm speaking to the choir, and you know very well about the immune response and the host of immune cells, the cytokine response, TNF, interferon, necrosis factor, and various interleukins, of course, just a few of them exhibited here. And in consequence, with the cytokine response, you get direct damage to liver, kidney, include the heart. You get impairment of the hematopoietic function, leading to anemia, coagulopathy, both micro and macro, leading to perhaps DIC in the most severe cases. All these things will lead to, of course, hypoxemia. What happens with the COVID illness, it really depends on the viral load and the response of the patient. So it's a hit or miss thing, but universally, the higher the viral load, the more likely you have a enhanced cytokine response. If the viral load is low and the patient has the appropriate immune response, we have resolution of the symptoms and resolution of the illness. However, especially if the viral load is high, we can talk about the Delta variant right now in particular, you get an enhanced cytokine response and out of control cytokine cascade leading to the course of the cytokine storm, which is causes most of the pathology that we see from a severe illness. This is looking at the various stages of the illness: initial viremia, secondary to the pulmonary phase, hypoxemia, with and without shortness of breath, without hypoxemia. This is normal pulse ox, this is low pulse ox. Eventually, with critical disease, we're talking about destruction or impairment of the hematopoietic system, coagulation, and destruction of the lung parenchyma into severe diseases. So we'd like to treat them here before they go on between 2B and beyond. And I'll get back to the treatments in a minute, but this is the stage 4, of course, is where the patient has irreversible pathology and damage to their organs. But we want to treat them, just like diabetes, we want to treat them early, not late. Here we want to treat them in this phase right here. And this, I'm going to show you how Glutaral does that. Again, I'm preaching to the choir, but of course in COVID illness, if it's low titer, we get a mild symptoms, supportive care, normal appropriate immune response and resolution. On the other hand, with the high viral titer, cytokine storm, we get lung injury, multiple organ injury, and of course, the risk of death, if not a prolonged recovery and severe post-COVID syndromes. Here we look at the various interleukins and cytokines that are produced from the COVID illness. as we know, the problem with corticosteroids is that you go from hyperimmune to immunocompromised state. So it's hard to regulate the proper amount of corticosteroids. Hydroxychloroquine and chloroquine, of course, it's as you know, it's a weak immune modulator, and it, of course, has that prolonged QT syndrome toxicity that can lead to arrhythmias. So there's a whole host of proposed treatments for various cytokines. And that, as we know, the cytokine response is dynamic and you have positive and negative feedbacks. One of the negative feedbacks is this between IL-6 and IL-10. And McCarran recently showed that not the absolute level of IL-6 nor IL-10, but the ratio that confers the prognosis of either recovery or severe illness. So you can see there's a dynamic feedback as well as sorry. And then schematically, you can see how it's hard to try and treat one particular cytokine or one immune cell. It's dynamic, there's negative, positive feedback. And so to me, trying to address a specific cytokine or would be like playing whack-a-mole. It's really evident futility. So what I propose is that what Glutaral does is works up here at the start, before you start getting the cytokine cascade, out of control cytokine cascade. And I'll try and show you what I mean by that. So what is Glutaral? Of course, is glutathione, as Dr. Patel mentioned. And it is delivered to the water channels via cyclodextrin, of course, which is a cyclic sugar molecule. And all of the ingredients, these are the primary active ingredients to have what's called a GRAS status, which is generally regarded as safe, and that thereby is considered over the counter. So I just kind of echoing some of what Dr. Patel mentioned, of course, of the low glutathione level associated with various diseases. The question is it just an associative marker, no influence on the disease process, or is it a causative factor? And if it is, the low level is a causative factor, well, restoration of that low level confer effective treatment of the disease. And if there's scientific evidence, and you can see by my big article below, the answer is yes. This is done by Chechenia. I like this because it graphically shows you some of the some problems of the COVID illness pathology. You have direct injury of the type 1 pneumocytes, not just depicted here, but you have the type 2 pneumocytes, which are also damaged. Of course, the type 2 pneumocytes restore type 1 pneumocytes, also convert the surfactant that allow the alveoli to stay open and expanded. You have the ROS, reactive oxygen species level, if it's high, causes the destruction of the tissue. High levels cause interstitial edema. It causes the microvascular thrombosis and also anemia, and also disruption of the mitochondrial process. All of these together will contribute to greater hypoxemia in an individual that has COVID illness. So you can see it's not just the direct parenchymal damage, but also the others sequelae that. And the microvascular disruption or coagulation, I think, is coagulopathy is the reason that, and the subsequent oxygen hypoxemia is why we get the multi-system, multi-organ dysfunction and damage. So how does this come into play? With the cytokine dysregulation, you get the cytokine storm. So how does this happen? You have high ROS, mainly hydrogen peroxide. It stimulates nuclear factor kappa B, which in turn stimulates the production of cytokines, which cyclically goes back to increase the level of ROS. And so you get this spiral down, and the question is, how do you stop this positive feedback cycle? We have that the cytokine storm causes direct and indirect pathology, as I explained. It causes, and this is a consequence of thrombosis, micro and macro. In fact, it can lead to consumptive coagulopathy of DIC. Who had endothelial damage, again, it impairs oxygen transport. And the hypoxia in total causes multi-organ dysfunction and sepsis. So you can see how this whole process kind of cascades on each other and compounds the problem. So as Dr. Patel mentioned, this is our body's master oxygen, antioxidant, and reason ROS. And think about this is, especially with talking about corticosteroids and other immunosuppressants. This is not an immunosuppressant, it's an immunomodulator. The way I look at it, you have like corticosteroids, you go from too much to little, hyperimmune to immune suppressed. Whereas the glutathione is kind of like a governor, it just brings it down to a normal level. So it's really osteopathic and physiologic when you think about it. So we don't have to worry about getting immunosuppressed with this medication. It's what I call the Goldilocks concept, not too hot, not too cold, just right. And that's what I like about this medication. It makes things more physiologic and gets you back to the homeostasis. It protects from the cytokine storm, and again, that prevents apoptosis and fibrosis. Interesting, what I found out from Dr. Patel is that in China, as far as the fibrosis, it's used for postoperative to reduce postoperative scarring. So I think, and my personal experience, I have a keloid. Lo and behold, I didn't realize it, but over the several months I've been using it myself, my keloid is resolved, almost resolved. So it does something about fibrosis. I thought keloids didn't change, but mine did. So it does affect fibrotic process. Again, by transdermal administration, it overcomes the barrier of oral degradation of the glutathione, because it's not how much is in the pill or the whatever it is, how much goes into, like Dr. Patel said, into the cell. We can get a high level of glutathione intravenously, but that's infusion, and we talk about the cost and the technical limitation that comes with any intravenous infusion. So this looks at SARS-CoV pathogenesis and what the cyclodextrin does. What it does is what happens is that the ACE2 receptor has a lipid raft, and this lipid rafts are kind of like condensed cholesterol-laden microdomains in a cell wall. And since the lipid raft is part of the ACE2 receptor, when you affect that lipid raft, it's kind of like changing the lock in a house. So if the key is the virus, the lock has changed, it's not going to enter the cell. And likewise, the endocytosis of the virus into the cell requires the proper function of the lipid raft. And which is interesting in the Delta variant is, one of the reasons why Delta variant is so virulent is because it replicates faster, 1,000 times faster than the Alpha variant. And also what they found out that it has what's called a cell-to-cell transmission. So it bypasses the antibodies that are out in the serum because it goes from cell to cell. So again, it's a oligosaccharide sugar molecule, and it's a delivery of all of the ingredients in Glutaral. And serendipitously, that of course it's through the water channels, which is in contrast to the lipid channels of the liposomes. But then, lo and behold, it's intrinsically antiviral. And when you think about it, it could probably be complementary to the current antivirals attack the viral replication. This attacks in a different area. So if you combine the two, I think you get a much higher ability to reduce the viral load. Again, like I said, it destructs the lipid rafts. So it impairs the binding of the viral binding to ACE receptors, viral entry, and finally the direct transfer. So I think this is really serendipitously the remarkable property of Glutaral, in particular from cyclodextrin. So what was originally thought to be a vehicle of transport of molecules is actually an effective therapeutic agent. Who knew? But serendipitously, it's remarkable. So in contrast to your monoclonal antibodies and the natural immunity, everything is out in the serum. Again, with cyclodextrin, you can also take care of things in the cell. Supplemental ingredient vitamin C is to stabilize the glutathione in the Glutaral, and also helps restore the endogenous glutathione from the oxide dimer. So I think Dr. Patel went through this about how it was zoster to influenza in COVID illness. So how are we going to get rid of the COVID pandemic? Vaccine prevention obviously is the key of that, and the higher the percentage we can immunize, the better, of course. Now we have the treatment that is Glutaral, so we can treat the cause with cyclodextrin, which is the viral load, the viremia, and the symptoms, which is from the cytokine storm, with glutathione. So we do that before we get the irreversible fibrosis and all the multi-organ dysfunction from phase 4 of the COVID illness. Again, avoid hospitalization, very, very important. Reduce deaths and days of hospitalization. We're talking about, I don't work in the hospital anymore. I used to, and I can imagine how it is right now taking care of these patients in the overwhelmed ICUs in hospitals. So not only just the wear and tear on the patient, but also on the hospital staff. I think it will treat some of the post-COVID syndrome problems, not the permanent damage, not the psychological, but the functional ones, the brain fog, the fatigue. So way back in 2020, we were looking at hydroxychloroquine, and you can probably put on this, the Ivermectin. And it's a very careful use of corticosteroids, which we now know is only reserved for later stages. So what do we have right now? You know, monoclonal antibodies, which seem to be quite effective in reducing the risk of hospitalization, but of course it's intravenous administration, so we have the cost and technical limitations of that. Molnupiravir, maybe is trying to get the EUA, emergency use authorization. Not yet, maybe at the end of the year. But Dr. Ben Gupta in MSNBC was categorized, and I think I agree with him too. This medication, molnupiravir, is kind of like the Tamiflu of the influenza. In other words, it needs to be treated early, the first few days of illness. It may reduce the severity of illness. It may prevent death, but it's not a slam dunk medication. It has some benefit, but it's not the answer to the COVID illness. We have remdesivir, antiviral. It's used early on. It's not to be used in what they're intubated and mechanically ventilated. And of course, dexamethasone, which is used only for people who are in fact intubated. And of course, they have that problem of over immunosuppression. So it's a problematic drug, although useful. So I'm saying that cyclodextrin works in this area early on to prevent the viremia that causes all the illness. But once the patient is in the hospital or has hypoxemia or furnace death, treat glutathione. So we treat the early and the late phases of the COVID illness across the board, and I can extend this arrow on the right side all the way outside to the post-COVID syndrome too. So the bottom line is, this is a medication that treats COVID illness all across the entire spectrum of illness. It should be able to, let me just talk about that. It's effective transdermally, and if you talk about especially young people, neonates in ICU, this is huge because oral and IV access is very difficult in these patients. It treats the cause and the effect of the illness. It's commercially available right now. We don't have to go through FDA approval and stuff. You can get it through Dr. Patel's company right now online. It's readily available. It's repurposed. It's stable at room temperature again. It's can be used in third world countries, rural areas, from your office. You don't have to send them to the infusion center. Prevent hospitalization. And probably treats the post-COVID syndrome. And there are certain vaccine side effects, especially on the young kids, and perhaps it might modify or prevent those reactions, which I think is a hyperimmune response. Again, to underscore, it is non-toxic. So I think it's this attitude of current regimens, at the very least, it's not going to do any harm. It'll probably do a lot of good, but not going to harm the patient by adding this to the current regimens. So future use, I think, save lives, just get the people out of the hospital, prevent deaths. That's first and foremost. And also, the population is much smaller than trying to treat everybody that has the COVID positive test. I want to treat the people that are most seriously ill and close to death. Get them out of the hospital. Once they are admitted, and presumably because they are hypoxemic, make sure they don't progress to requiring mechanical ventilation, get them out of the hospital sooner. Again, eventually outpatient treatment to prevent hospitalization. And then finally, treating the high-risk population, the healthcare workers, other critical workers like teachers and so forth, the elderly who are at risk of immunocompromised. I don't know how it's going to do, how glutathione will work, but definitely will reduce the viral load. So antiviral properties is very important for these people, because I don't know how much of an immune response they'll be able to achieve given their status and the drugs that they're on. The unvaccinated, currently, we're talking about anybody under 12. And at the very earliest, we may get the vaccine used for 5 to 12. But again, we lost those people who are preschoolers right now. And finally, anti-vaxxers, regardless of the political philosophy you have, we're not going to get rid of this pandemic unless we treat everybody, those that are vaccinated and those that are not. So if we can, and I think we reached that wall of the people that are going to get vaccinated have been vaccinated. The ones that are not going to ever get vaccinated. So let's treat them at least, and hopefully they will accept the treatment, especially if they're having shortness of breath. I'm sure they will. I have asthma. I had shortness of breath one time, and I can tell you, it's scary when you can't breathe. So I can feel how their reaction would if they were offered something to treat their illness. I'm sure they will do that. Post-COVID syndrome, I mean, interesting to see what happens with those symptoms. Some of them, not all of them. Reduce contagion. I think I would like to look at this as kind of like treating STIs, where you identify people that have the test positive, then contact trace to treat them early before they spread it, before the variants occur, and before they spread it to anybody else. How does it affect antibody response? This is not prevent the disease, but how will it affect antibody response? Will it be as robust? I don't know, but it'd be interesting to see what if it was the antibody response. Other diseases, this has been shown to affect for RSV and respiratory syncytial virus. And of course, this is something that's quite prevalent among the pediatric population, and there's not much you can really do other than supportive care right now. This could be a treatment for them. Kawasaki's, they say there's a Kawasaki-like syndrome for some of the young people. And I think it can treat that, and also the Kawasaki disease itself, because what we have right now is high-dose aspirin. Viral myocarditis, it's intriguing. If we can treat those people with the viral myocarditis, perhaps we can, by reducing the viral load and also the inflammatory response, we can probably save them from having lifelong heart failure. All the various forms of herpes, zoster, simplex 1 and 2. Treating simplex 2, genital herpes is problematic and very poorly done with the antivirals right now. This should remove the symptoms in 2 days. The cytokine storm was first identified 2 decades ago in the graft versus host response. So if that's the case, and it was the cytokine storm that causes the graft versus host disease, can we treat it? Perhaps it'd be, again, it's not going to harm the patient, so let's see if it does. I'd like to see it there. Fibromyalgia, you guys see that more often than I do. Is it? I've seen on the news or advertising the cytokine markers, and it's cytokines. So to me, perhaps fibromyalgia may be a disease that can be responsive to Glutaral. Won't hurt. And finally, I have a patient, my coworker in my clinic has the TRAP syndrome, and population of study of 1, and see how he does, because he doesn't want to be on the immunosuppressant agent right now. So we'll see if that helps or not. Again, that, as you know, it's not so much that it's a high level of TNF, but it's just that the response to the TNF is heightened. So it'll be interesting to see if it can modify his symptoms when he has his attacks. But bottom line, save lives in the pandemic. And I don't know about you, but I'm getting tired of wearing my mask. I want to hug my friends, my family, and I want to be able to go to the theater and restaurant without worrying about catching the darn virus. So that's what hopefully that Glutaral will do. So I don't know if I convinced you guys or not, but I'm thoroughly convinced, and I'm thankful for that. Dr. Patel was able to create this remarkable product. Any questions?
Thank you so much, Doctors Patel and Yutani. Dr. Patel's been answering some questions in the chat room, but maybe we can go through a few of those. I think they're fairly relevant. So,
Bill, I have a question. This is Dr. Patel. There's a question that in the sick patient, particularly when we are talking about COVID-19, they have a poor peripheral perfusion. And by just doing the application on the skin, transdermal absorption, how can we believe that that transdermal absorption is going to be optimal and we are going to achieve the good results?
Well, I can answer that for the people that I personally gave this medication to. They felt, the ones with shortness of breath, they felt better. They breathed better the next day. So to me, that means that either by lowering the viral load, addressing the cytokine storm, or both, they they weren't well, but they were started to recover the very next day clinically.
Do you have
How
the measurements?
can we rely on 24 hours or next day? We would like to see the results in 2 hours because, you know, the clinical presentation changes very quickly.
Well, of course, you know, but it is what it is. Perhaps with intravenous, there was this article by this one physician back east. He gave intravenous glutathione with response within hours, but again, this is we're talking about transdermal. So I think short of intravenous, this is the best therapy that we can offer to patients. Again, we're not restoring glutathione, we are administering glutathione. So to me, several hours is better than no response at all. Not ideal, but I think the best we can expect.
Do you have study measures the absorption rate? Like, you know, you're putting on topical this amount, how much you get into the blood? Did you hear my question? It's frozen.
You know,
Sorry, I was muted. I do have an answer for that one. For the topical absorption, we are getting serum levels in the red blood cells anywhere from 500 micromoles per liter to up to 900 micromoles per liter within 45 minutes, which shows about 88% absorption through your skin. Of course, the cohort was only 5 patients, but all 5 patients, we got anywhere from 88 to 90% absorption through your skin into the red blood cells. So that is better I think is better than Dr. Horowitz, who did the IV preparation and gave, I believe, 1 gram of IV, and the levels that's rising in your plasma has a very short half-life, anywhere from 10 minutes to up to 2 hours maximum. So I want to believe that IVs are going to be working good for us, but understanding I was making IV glutathione for the last 20 years. I've never seen dramatic results what I've seen with the topical formation for the first time. So the absorption is there. Again, we are recreating the same study again at the university under an IRB protocol, so that we can publish the data once and for all.
You know, you have to realize, even in bacterial infection, we give intravenous antibiotics, and we would only expect them to do well within a few hours. We expect them to be better in the next day. So I think to expect that, even though you may get therapeutic levels of glutathione, response to that by the body will probably take hours and not minutes.
No, I believe glutathione works very well, but I think Dr. Cheryl will agree with me because I think I learned this from her. Repeating using it because it contains glutamate, and glutamate itself is pro-inflammatory. So you may get good results in this first and second shot, third, but if you do it too much, it may lead to some glutamate toxicity. So I would like somebody to comment on that. And I think Dr. Cheryl is the one I learned from her that point, which is a very good point.
You're writing about the optimal dose of Glutaral. That remains to be seen, but at the present time, I think our goal is to try and save some lives, and we've shown that it prevents hospitalization and recovers. I can tell you I have not been able to administer this patient to people in the hospital because I'm not a hospitalist. But I had this one patient of mine who was a mother of one of my own patients. She was in the hospital and had a pulse ox in the low 70s, and they were going to transfer her to the ICU. My patient, her daughter, said, "I don't want my mother to die in the hospital." So she took her mother home AMA, and this is unbeknownst to me. I found out after the fact. She brought her mother home to die at home with supplemental oxygen. She gave her mother Glutaral, and 4 days later she was well. So this is an indirect.
Well, I can give you a better answer for that. If that patient went to the ICU, definitely they're going to intubate her because that's by law. If the oxygen is less than 90,
that's why she was going to be transferred to the ICU, right?
Right, they will intubate her, and intubation means blowing her lungs up. So the reason she's survived because she's using regular oxygen supply with that low oxygen. It does not matter because they have what we call silent hypoxia. So what saved her really is avoiding the intubation. And then yes, maybe glutathione did help to speed the process and maybe neutralize the free radicals, preventing lung fibrosis. There's a good benefit from that, but what saved her for her life is avoiding intubation, and most of the death is caused of intubation.
Talking about the barotrauma, is that correct?
Yeah, because they have silent. We're going to talk about this thing maybe next week. I'm going to present it here. We're going to talk about silent hypoxia or happy hypoxia, and they're using the same protocol for silent hypoxic respiratory failure with the reactive hypoxic respiratory failure. And that's completely wrong. And I think that's the reason we see the number of deaths is high. And that's the reason in Italy, they don't do any more mask CPAP. They do helmet CPAP, whole body CPAP, because mask CPAP also has some barrel pressure there on the lung. Intubation does. And the difference between silent hypoxia, reactive hypoxic respiratory failure, we're going to discuss that next week here in this conference with Dr. William. Hopefully everybody will be attending, but you will see there is a big problem in the ICU in the management of respiratory failure. They putting patients on tubations. If their partial oxygen pressure is less than 60, means their oxygen saturation is less than 90, and they are on oxygen supply, right? They intubate them. And those patients on those level of oxygen, they really don't feel any dyspnea. because what we call the silent hypoxia. We're going to talk about it next week. But I think that's the reason. The reason she did not die, because you took her from the hospital, you give her regular oxygen, and yes, the glutathione possibly helped to speed the process of the healing, neutralize those free radicals, and preventing lung fibrosis from the oxygen itself, which oxygen itself can lead to damage, but the damage from the pressure is way more aggressive and more pathologic than just oxygen.
Well, I agree, because people think that with ARDS you have a uniform lung tissue, but you have pockets of good and bad. So you traumatize the good, trying to oxygenate the bad. But anyways, what my study was not done for inpatient treatment, but when you think about it, if you can prevent the hospitalization and prevent the progression of hypoxemia in those that were hospitalized, I think that's where this drug is probably most effective and probably used the most.
So one of the questions in the chat is, in your study, was it only on with Glutaral alone, or were they on other modalities?
No, these were these were people that were at home, so they were not on any other medications.
They may have taken some Tylenol on their own at home.
Okay, but they weren't on, a whole protocol.
They were not on remdesivir. They were not on anything else. So those were not. This was early in 2020, so all those those medications were not even being used at that time. They were not options.
Another
What is the
question.
cost of Glutaral?
I'm sorry.
What is the cost?
Oh, yeah, it's on the Oral Wellness website, aurowellness.com, and you can just check on the website, and and you can only buy as a provider and sell as a provider, so that way it just makes it very convenient for patients to not to buy, and then for providers you get 45 to 50% off the pricing for wholesale.
So for the physician, what would be the cost? So everyone knows about it.
So 45 to 50% off. I'm not sure the exact percentage. That's why I put it. It's up to 50% off. I think it's between 40 and 50% off the retail pricing.
So is it like a $40 for the physician? Or?
The Glutaral is $120
Okay.
retail, and the Glutaral Plus is $200 retail. And so the half of that would be the cost for the physicians.
And what is the volume?
30 mLs. It's a 1 month supply if you're using at half an ml BID.
And half ml BID is what is the milligram?
So half ml for Glutaral will get you 100 milligrams, and the Plus will get you 175 milligrams of glutathione. Keep in mind that the cost is not the glutathione. The cost is actually the cyclodextrin. Cyclodextrin in the United States, it's a GMP grade material, which there's only one buyer in North America, which is us. There's not a single buyer of this molecule in North America at all, and the price is absolutely horrendous at this time. So hopefully if the volume picks up, the price will probably go down in the future. We're not sure yet.
Why would they do that then? Another question, can you use Glutaral in conjunction with Ivermectin?
Yes, there's no contraindication for glutathione whatsoever. The only thing that we see there's a contraindication is if somebody's using a chemotherapy medication and glutathione, it will negate the effect of chemotherapy because chemo is a pro-oxidant and this is an antioxidant. That would be the only thing that I would see. Other than that, there's no contraindication with any medication whatsoever.
If it's a sugar molecule, can it aggravate blood sugars?
No, it does not. It does not increase blood sugar levels at all. We have time and tested every single time, and we have not seen any increase in blood sugar levels. In fact, it's the opposite. What we have seen is the sugar level starts dropping. The A1C is what we measure starts dropping after prolonged use of this product, and so that requires another study on its own.
Do you have intranasal formula and inhalation formula?
No. Well, the thing is, we do have the formula in the compounding pharmacy as an intranasal and inhalation solutions, but again, there's no need for those molecule products if if the topical actually is working. This particular product cannot use intranasally or inhaled solutions because of it's an irritant to the mucosal membranes.
It doesn't help to skin whitening.
Yeah, it does. But again, that's a whole new ball game. It's for the cosmetic reasons. We do have this product approved in China as a drug for the very purpose of post-surgical scars and skin lightening.
Have you used it and have you compared it with the IV form of glutathione as far as efficacy?
So I have not compared with the IV glutathione for efficacy, but I'm just looking at theoretically. I cannot inject everybody every single day, and since the half-life is so short, it doesn't matter if I give a 2 or 3 grams of dose of glutathione IV. It's how much your body's going to retain. And so if the body's going to retain so much for so long time, I'd rather give them more frequency. So the question always comes up. I said, hey, can I use more sprays at a single dosage? I says, no, there's no cost benefit ratio. I'd rather use it more frequently than to use a bigger dose at one point. You'll get a better result that way than to try to use a bigger dose at one point. So no, I'm not in a study yet.
And when did you suggest to use the plain versus the plus?
So plain is what we have been using for all these years. And the plus was released this year. And the only reason was because we had a very celebrity status. Dad was in the hospital and with COVID for 21 days, was not going to make it. And he heard about this glutathione product that we had. And so we said that we have a plus. We have not given to anybody yet in the hospital setting. So we like, if you want, we can give it to your dad. But the thing is, the hospital is not going to approve the usage. But of course, his name carries a lot of weight. He can make a phone call to the president. He'll probably come to his doorstep if he had to. So he made the call, and they approved the use of the product on his dad. And 7 days later, he was back home. And so as soon as that happened, of course, he's a ball player, and right off the bat says, "Hey, I need this product for all my teammates." He's an NFL athlete, and so all of a sudden he got the whole product. So that's the reason we released the glutathione plus at that time, but the plus was never released until this year. So all the studies we have done was just a regular Glutaral until this time. So if ever in doubt, if you just go with the regular Glutaral, I think you can get the results that you're looking for. It may take a little bit longer than normal, but still, it's still way better than what we had before.
You know, the questions about how efficacious this is in the hospital, that hopefully this will spur some studies just to compare. And to me, add to the current regimen, because it's not going to harm the patient. And if it helps, so much the better. But I hope this provides some double-blind studies looking forward for hospitalized patients.
So there is one side effect of this product. And if normally with glutathione, there are no side effects, but the rate of absorption is so fast that we have intense amount of nitric oxide production in your body. And when that happens, some people may develop a rash. And the rash is not necessarily at the application site. It could be anywhere in your body. And the rash usually dissipates once you stop using the product. But the rash is something that we have noticed time and time again. And literally once a week, I'll get a call.
Is it itchy? Is it itchy rash?
It is not an itchy rash. It could be itchy a little bit, but I'm not seeing an itchy rash.
Because there's two kind of rashes. If it's allergic rash, that means Th2 dominant. That means histamine mediated. But if the rash is not itchy, that means it could be Th17 or Th1. So how are you treating the rash? Is that just giving them antihistamine for people who are not itchy? I think antihistamine will not work.
No.
What are you doing it? We'll just discontinue.
Discontinue the use for a day, then start with a lower dose and slowly build up the dose again. So the half a cc is what we recommend, which is 4 sprays BID. So I tell them to start with 1 spray BID. After 2 or 3 days, go to 2 sprays BID, and every 2 or 3 days they increase the dose until they don't get the rash. And it's when they first start off, they get the rash. And sometime after a year of usage, they get a rash. So regardless, we always tell them stop the therapy, wait for a couple of days, then start slowly again, and then build up the tolerance again. And it seems to be working fine so far.
Is it because of cyclodextrin is irritant?
No, cyclodextrin is completely inert. In fact, cyclodextrin is in all your food. All the preserved, all the packaged foods, they use cyclodextrin to get rid of all the smell. So it's completely
Oh,
inert.
so it does help to remove the smell of the glutathione.
No, it does not. We tried that part. It still stinks. I'm sorry.
I see.
Yeah,
I see
because it smells like an egg.
Yep.
Rotten eggs. So the question is, do you want to smell bad or be dead? You know,
Because I'm a fan of NAC, N-acetylcysteine, but the same thing, problem with it, it smells like rotten eggs. Because all thiol, sulfur hydrogen, it's the same thing.
The smell dissipates in about 2 minutes once you apply. It goes into your skin, the smell dissipates. So it doesn't linger on for more than a couple of minutes.
I think if you add polyethanol amide to it, you will remove the irritation. You know that polyethyl amide? It's very good for all the topical cream was irritant. Just add polyethyl amide, and the irritation it will go away. And you can go ahead and search polyethyl amide. They're using it for contact dermatitis and allergies of the skin, so it may help that to with that.
Well, thank you for the suggestion. The rash is not happening at the application site, not necessarily. You apply the tummy, and the rash may happen on your face or on your legs or on your arms. It's non-specific. It doesn't apply where you apply the medicine. So that just tells me that something else is going on.
We get them occasionally when we gave it IV right at the IV site, and like ended up correlating it with a zinc deficiency. I don't know if it has any correlation with what you're talking about, but usually we give them zinc picolinate 30 milligrams twice a day for about a week, and the rash would be gone. So.
Oh, wow. No, thank you. Now that makes sense, because most of the people that are getting the rashes are severely immunocompromised or highly stressed type cases. And the stress may be depleting the zinc levels in these people. So that could be one of the possibilities as well. But I'll look at polyethylamide and zinc deficiency and see what that. I'll definitely. I have plenty of people with rashes, so I can definitely try that out right away.
I know you answered this in the chat, but someone asked where do you apply the Glutaral? So
I usually apply on my belly, non-hairy area. My belly is quite a hairy little bit, so I shave my belly a little bit, or the obliques. It's away from my nose because it smells awful. Of course, if you tell my wife, she'd like to put it in her face because it definitely has a very good, powerful antioxidant effects for your face. So my wife applies on the face and neck and takes care of the wrinkles that way. But I apply on my obliques all the time. Hopefully, I'll get a six-pack one day if I keep on doing that. But it's not working so far. It is a sticky base. The polysaccharide is sticky, so if you apply it on, you just have to rub it in for about a couple of minutes. It will dry up. The full treatment is 45 minutes, and then if it still bothers you, that area of application, you can take a washcloth and just wipe it down. It's water soluble, and you're done. I typically apply in the morning before shower, so 45 minutes later, I take a shower and I'm done. In the evening, it doesn't bother me.
Do you know something is called misk? I don't know, it's Arabic term, but it's a perfume, and it's from the nature. It's coming from, I think, the deer, but it smells so good, and I think that will take the order of that. It's called misk. Have you heard about it? No.
No, Dr. Halas, I'll reach out to you especially to find out what that is. Is misk M-E-S?
Misk. The Saudi Arabians and Middle Eastern, they use it a lot. Misk.
Okay.
M-I-S-K maybe. Misk.
I'll definitely find out.
It's a misk perfume, but it's very natural. It's a natural thing, so it's not chemical. But that, I believe, will take off the order completely. Yeah, so something you may consider.
So 8 years in a row, I tried to mask the smell, and the formula I had in 2009 and the formula I have in 2021 is identical. Hasn't changed yet. And that just tells me that no matter how much I try, I'll destroy the complexes. So I hate to keep on trying things, but I'll definitely, if I can get rid of the smell, will be heaven for all of us. So I'll definitely look at that one as well. There was a question about Lyme's disease. And no, I have not tried Lyme's disease to a point where I can surely say it's going to help. So it's not going to hurt them, but I have my doubts it's going to help them. But keep in mind, like even with Parkinson's patients that we have tried on, it may not remove all the jitters and the shakiness and all those things, but the quality of life improves, the energy level improves, they're functioning better. So even though they may have all the symptoms, they're able to function normally. And so same thing in the Lyme disease, it may not help with the Lyme disease completely, but if they can increase the energy and fatigue goes down, that's still a plus point in my dictionary. So.
The next question is about mycotoxins.
Yes, so I've been working with Dr. Andrew Heyman out of Virginia at the George Washington University. He's also the chairman at Anti-Aging Conference A4M, and him and I've been using for mycotoxins for the last year and a half. And I literally get a patient to two every single day from him with mycotoxins, especially the black mold. And we have a lot of people in California with that, and we've been using that for quite some time now. And I don't have any data to support it at this point, but I know he's presenting it at the Anti-Aging Conference in December of this year with this data. So I have to wait and see until the presentation is ready, so I'll learn more from him too.
Speaking of toxins, I think this could be used for mushroom toxicity and also for Tylenol toxicity too.
Yeah.
Just to see how that works.
Anne asks if it can be used as a preventative for, or sort of a maintenance, like a weekly dose.
So again, if you just take it once a week, it's not going to help anything. Even if you use it daily, I don't think it's going to prevent you from getting COVID. But by all means, if the viral load is low, you're not going to feel the effects of it as well. So we have quite a few cases where the patient have been taken for preventative purposes because they heard from Tony Robbins and his friend circle, and they all got tested for antibodies, but they never got any symptoms. So they didn't get, but there are very few cases like those. So I'm guessing that the load was low enough for them not to develop symptoms, and so they were okay. But I cannot with my whole heart say that this is preventative for COVID. Probably not.
Okay, how about SIRS?
Well, that's the hope, right? That's the hope now. We did not even knew about COVID until last year, and so everything else, it's we can all hope for it that we can at least try some of the patients on these ones.
These are all the studies that like to be done, prospectively in controlled studies. So, but we have a medication that may be effective and it's not toxic, so why not give it a try? Because what can we do right now? We're pretty limited on what we can do for SIRS and sepsis and stuff like that.
Mm-hmm.
Someone mentioned something about IPT, low dose chemotherapy. You should not use this.
Yeah, and that's the part that's always troubling to me. In theory, this is absolutely going to negate the effects of chemotherapy. So knowing that theoretical chance, I would probably say not to use this product with active chemo drug together. We did have a doctor that was using Rotaxin for her folliculitis, and she has an autoimmune condition. And even with the medication, she was still getting breakouts at least once or twice a year. And she used the product, and literally at the onset of breakout, and 3 days later, she was completely free of all the symptoms. And for the very first time, she saw a hope in what she was suffering for almost 20 plus years. So again, it's 1 or 2 cases doesn't say anything, but if we start, the whole point about this presentation was to open your mind up to see, hey, there's something possible out there. And we want people to come with us on this journey of discovering new ways to do better things. And we are here to support anybody's activity. If somebody wants to do any research trials, we are here to support anybody and everybody to help them out with that.
Again, it's non-toxic, so the additive no harm.
Okay.
So why not add it to whatever we have right now?
Yeah.
Someone who's been on N-acetylcysteine and wants to continue, can you use both?
Yeah, you can, but absolutely N-acetylcysteine is useless once you take glutathione, N-acetylcysteine would not do anything for you, because keep in mind, N-acetylcysteine requires your body to produce the glutathione, and it will take all the 3 amino acids. Cysteine will be provided by NAC, but the 2 other amino acids plus the enzymatic reactions to make glutathione. If you take an exogenous source of glutathione, your body will not produce the enzymes to make the glutathione. So NAC is useless at that point.
Have you used that in autism?
I'm sorry, one more time.
Autistic cases?
Oh, yes. So autism, we have literally hundreds of thousands of cases for those. The dosage is different because for autistic kids, we are only giving them 50 milligrams per dose. And no more than 50. Unless they are 12 years and above, then we give them 100 milligrams. But other than that, under 12 years of kids, we are giving everybody 50 milligrams dose only. Anywhere from 1 year onwards to and onwards, we are giving the low dose. The symptoms, if you see the symptoms relieve in the first month, this is a great product for you. If it doesn't happen the first month, it's not going to work. That means there's some other condition that is causing autism other than detoxification pathways.
Okay. Inflammatory bowel disease and associated arthritis.
Yes. So we do have a few cases of Crohn's. We have a few cases of arthritis, completely separate out. And arthritis, the best example I have for arthritis is my dad, who's 86 years of age at this point. He walks 6 to 7 miles per day. He had arthritis for over 40 years. And today, if you see him, he is living his life for the first time without any pain, and he just walks every single day at the age of 86. But he's been using for almost 8-9 years because he was my N1 since I discovered the product. He was a patient number 1. So he's not a good example. The good examples are I have a 12-year-old with Crohn's disease that we were able to have a symptomatic relief within 45 days. So.
What about using it with low dose naltrexone?
LDN is my cornerstone. I probably have, I don't know, a few thousand people on LDNs through my pharmacy every single day. So I would not shortchange LDN by all means. It's a must because it modulates receptor sites in so many different ways that glutathione cannot do it. So as a great adjunct therapy to LDN would be a glutathione for sure.
Okay. Just a personal plug. So I'm giving a talk at AMMG next month, first weekend in November on low dose naltrexone. So,
oh, awesome.
Personal plug. So we can put yours in too. Okay. I don't know. You guys are going to be there at all?
No, we are not going to be there this year. I may have to call Rick and ask him to be there, but I've not decided to be there because for the last 2 years, it's been so chaotic. And it's one of those things that which conference you would really want to go to at this point. So. Okay.
Somebody put in a question about can LDN be taken by a healthy person? I guess.
Yeah, I guess so. It's the toxicity is not noted when you start prescribing less than 50 milligrams. So LDN, you're talking about 1.5 to 4.5 milligrams QD. There's no associated toxicity with it. And now we are also using ultra LDN as well, the very low dose naltrexone as well. So some of those patients.
Yeah, I go into that at AMMG the first weekend in November.
Is it
as a little advertisement?
Is it virtual conference or is it in person?
No, it's in person. Well, so far it's in person. So,
oh, awesome.
So we're only a couple of weeks away. So OMED, which we mentioned, is the AOA Scientific Convention, and that's next weekend, and we were supposed to be in Phoenix, and they kind of we're online. So with that one. So anyway, okay.
I got a question, and this is a mutual question from Dr. Crowley and myself. This is a transdermal glutathione, right?
Yes.
So is it the nanotech that's letting it get through the skin, or are you using a driver, or is there another element we're not aware of?
No, it's not. There that was the funny part because the fastest approval we had from NFL was less than 2 hours. We submitted to NFL for approval. There are only 4 ingredients inside. And NFL looked at me and said, "You're serious? There are only 4 ingredients, and you tell me to approve this product?" I said, "They approved it right away." So water, which everybody knows, glutathione, ascorbic acid, and cyclodextrins. Only 4 ingredients inside. And the process of making the glutathione nanotechnology is we are using protein enveloping method with dextrins. And what we're doing is we are closing the whole molecule into under 1 nanometer. As you can see, nanotechnology is 500 nanometers. This is under 1 nanometer, which is make this as a sub nanotechnology, which is absolutely different than anything else in the market today.
So that's the key to getting it through. It's the size.
It's the size of the molecule. Yes.
That's fantastic. I want to ask you one more question because I've had this for about 20 years since we have the experts here. Are you familiar with ASEA, ASEA water that claims to raise glutathione by simply just sipping the water?
AC.
It's ASEA. It's called ASEA water. I spoke to the owner and the research scientist there some 10 plus years ago. And they were taking maybe a tablespoon, 2 tablespoons of this water, and their glutathione would go up 300%. So I never could understand that, or I thought you might know about it.
No, I have not. And thanks for putting.
I do know about it. It's a redox negative, redox positive water. So basically, they take the water, you pass through electricity, and make it positive, redox potential, like 800 positive. And what it does, it's just like a spark of free radical, and it triggers the expression of antioxidants. But once you open the bottle, I don't think the rest will be okay. Although they're putting some stabilizing magnesium there to stabilize the redox potential of the water to stay positive. But that's what it is. It's more of like a spark of, like ozone, okay? And like oxygen therapy, it's the same concept.
Thank you.
Is it working? For some people are working, but the claims are too big. And FDA, they went after them a lot. So they are outside the United States. They're marketing mostly in Mexico and South America. And I know the guy who was inventing it, I think his name is Dr. Gary Samuelson.
Is it a high pH water?
No, it's the redox potential. We have to know the difference between pH, which is the acid and alkaline, redox potential, which there is a cross between them. But those are redox positive water.
Okay, so the reason I asked this question is because there are a few companies who makes this types of water. I know the Prince of Saudi Arabia, MBS, Mohammed bin Sultan, is using this type of waters in his and the Dr. Francisco at in the palace itself, making this water for them.
Yeah, that's a Zemzem. They find the water under the Kaaba. There is water. It's under where they pray in Saudi Arabia, and it's actually the opposite. It's redox negative. It's like hydrogenated water. You know the
exactly.
hydrogen water?
That's exactly right. So
right, that's hydrogen water. That's another extreme of the water, which is redox negative, which directly neutralize the free radical. The same thing like glutathione. So that's hydrogen water or redox negative water. But I see it's the opposite. It's like ozone. It's like oxygen therapy. Hydrogen peroxide is the same concept. So if you think ozone works, hydrogen peroxide work, I see it work. But once you open the bottle, the stability there is not that much. So the rest of the water, it's better to drink it the whole thing, or buy small quantity of it and drink it all. But don't buy the big one, because once you open it, it's like the sparking water. It goes away, the spark.
Thank you.
And if you do want to measure the glutathione levels, I would suggest you measure the RBC levels, because plasma levels has a very short span and is hit and miss. Doctors' data will do the testings, I believe so, for the the erythrocytes levels of the glutathione, which will give you the best results.
if you really want to have reliable testing about the effect of your medication and really come up with publication that people will take it seriously, is measuring the gluteal function test. So basically, you measure the gluteal function test, it's poor, and then do the cream, and then after 3 months, you measure the gluteal function test. If you improve it, then your topical cream works. And I think it's so simple to do it, and we can rally around it. I can connect you with the diagnostic company who's doing it. So you may collaborate together where he will provide you with a network of doctors who are having the system and you're providing the medicine, vice versa.
Absolutely. That's the whole thing. We want to connect with people that will do studies on it. So Dr. Halasa, I'll definitely reach out to you for that one.
You have my phone number. We know each other a lot.
Yep, I do have
We're
you.
meeting you a lot in the conferences.
Yes.
Hi.
What about, have you measured the cytokine levels before and after?
That's what I would really like to do, in the hospital. Like, measure cytokine levels. Yeah, that would be obviously part of any study looking forward.
Okay. And anybody else? Any questions, comments, complaints? Complaints, take them outside. We're not interested. So thank you, Doctors Yutani and Patel. This was fabulous. Those of you who are regulars here, last week we had Dr. Stock, and I think we've stepped it up a bit here as far as our presentations, and I'd really like you to at least bring one person with you so that we can again expand our reach here. Thank you so much. It usually takes me about 48 to 72 hours to get the presentations on our website. I put it in the chat room. I'll put it again. It's, hang on, let me go, everybody. It's aosrd.org/webinars. And we have just about every one that we've done. We've been doing this for about a year, every week. We've had some great presentations. I think the last couple of weeks have been outstanding. And we can't thank you both enough. Hopefully you'll come back and report to us down the road a piece on your progress and the fact that you were the cure for COVID. We'll be looking forward to that, as I'm sure you would be.
I think this is the best kept secret in the world right now. So hopefully we find.
So do you think? So the hospital that refused to treat the patient with ivermectin, if we could sneak your stuff in, you think we could get that by the guards? They won't even know what it is. Usually it's yeah, okay, fine.
That's great as a nurse, ICU nurse, and get in there.
Yeah.
Yep.
Usually a couple of gift certificates to some.
It's so easy to
restaurant.
smuggle it, because you don't need to smuggle it, because you can say this is for cosmetic use, for whitening of the skin. How about that?
Yeah, well, with PO2 of 68, I don't think that their skin's probably white enough.
There you go. Yeah, we were pale.
Okay. And so next week, I still don't have I don't have a speaker lined up yet, but we will.
Oh, you do. You have me. You told me, right?
Oh, you got you. Okay. Dr. Halasa is back. He was away for the summer. So
no,
back.
you text me. You told me that I needed to speak.
Right. You do.
People want to talk about methylene blue. Remember?
Absolutely. Right. Yes. We need methylene blue. So we'll be next.
So Bill,
Yes.
this is Patel.
Yes, Dr.
So then you are going to have Halasa. So I'm not going to be there, right?
Who, me?
No, myself. You told me to finish my second part.
Yes.
My lecture.
If Dr. Patel, if you want to go
So
with second part next
I was
week,
going to be next week.
okay,
Yeah,
go
that's
for it.
that's
Go.
what I was
Give it to
scheduled.
Patel. Give it
All
to
right,
Patel.
Dr. Patel, you do next week, the 19th, and Dr. Halasa, you can do the 26th, okay?
That's fine.
And that
Ladies first. I'm very gentleman.
Okay.
Me and you.
All right. So real briefly, So next weekend, the 22nd to the 24th is OMED. If you're need CME credits, AOA or AMA, if you sign up for it, please sign up as members of our group, because we get bonus dollars for our organization. We are presenting that they don't like us very much. We tried to change our team name from rheumatic diseases to integrative medicine, and the AOA didn't like that very much. So they've been kind of trying to stomp on us, trying to get rid of us altogether. But Dr. Burgess and I outfoxed them. So we're back in, and we'll be there. We'll be doing our presentations. They didn't like the fact that a couple of our speakers own some businesses for some reason. That's a problem, and I'm going to find out if they threw anybody else out in any other groups. But that's neither here nor there. But again, if you are going to be signed up for OMED, please sign up under our name, even if you belong to the family practitioners or the internal medicine. They don't need it, we do. Please bring a friend, one friend. We can expand our group. We had a couple of new people tonight. I started chatting with anybody who would say that they might be interested on LinkedIn. So we had a couple of new people tonight. Doctors Yutani and Patel, please come back anytime. We're here every Tuesday night. I will send, well, you have the link. It's always the same link. I'm gonna, if it's okay with you, I'll put you in our email
Sure, that's
base.
good.
And if you don't want it anymore, just unsubscribe. Please don't complain, and don't threaten to call the California Attorney General, like a certain dean at a medical school did. Believe it or not, at the osteopathic medical school, no less. So with that, I'm going to say, anybody have any questions, comments? Okay, Dr. Patel, just send me a title for next week. Dr. Halassa, you'll be the week after. And by the beginning of November, Doctors Yutani and Patel will have cured COVID, and they'll come back and report to us on their great success. Okay. Dr. Burgess, anything? No? Okay. All right, everybody. Good night. Thank you so much.
Good night. Good night.
And we will be back next week, same time,
All
same
right,
station.
take care.
Okay,
Bye.
take care. Thank you so much, gentlemen.
Thank you.
Good night. Thank
Good
you.
night. Good night. All right.